Minesh?
Yes, ma'am. I'm just doing it, updating it.
They're asking me, that's why.
Yeah. Just a minute.
Yeah.
It is just navigating to the live.
Ma'am, it will take 30 to 60 more seconds.
Okay, okay.
Yeah. Yeah, ma'am. Now we are live.
Okay.
So now participants can watch.
Yeah.
So we'll start if you want, ma'am.
We'll wait, let them enter, no? And
Yeah,
some participants, then we'll start.
Yeah, it's live.
It's live now.
CS. Yeah.
Minesh, what is the YouTube link? Can you put it on the group?
Yes, sir. I'll do it. Wait. Sir, for YouTube link, the coreconnect.live, I'll just share on the group. I'll share.
I can send it to my friends.
Sir.
It's ironic, isn't it, that the link says Corona is inviting me.
Yeah.
Not the virus, sir.
Not virus, sir, but
Yeah.
Sir, the webinar PDF is shared, sir. That has that Core Connect link in that.
.org
you
/live.
can click YouTube live also, sir.
Yeah, that link only, but I am going to share again on the group, sir.
Okay.
See, I have shared in the IUGR talk group, sir. Click on the link and go for the YouTube live.
Oh,
I think YouTube live is not at.
Go live webinar ऐसा लिखा है ना, उस पे चले जाओ.
No, I have opened on YouTube, but वहाँ पे नहीं दिख रहा है.
सर YouTube में नहीं, आप में coreconnect.org/live.
हाँ.
वो मैंने लिखा है ना जो ग्रुप में, उसको क्लिक करोगे नीचे आएगा गो YouTube live, उसमें आ जाएगा.
okay.
I'm just doing it.
Yeah, आ गया.
Done, ना?
Yeah. I think YouTube live is not.
Go live webinar ऐसा लिखा है ना, उसपे चले जाओ.
No, I have opened on YouTube, but वहाँ पे नहीं दिख रहा.
सर YouTube में नहीं, आप में coreconnect.org/live. वो YouTube live, उसमें आ जाएगा. Can you see here, ma'am? Right. We are live.
Minesh, participants have entered?
Yeah, ma'am. I saw this 45 people entered.
Okay. Shall us wait or?
If you want, you can start, ma'am. I'll just share if you want the presentation, that PPT of Dr. Jambunathy.
Yeah.
You can start if you want.
Can you see here, ma'am?
Jambunath sir. Participants have entered.
Yeah, ma'am. I saw this 45 people entered.
Shall I wait or no?
If you want, you can start, ma'am. I'll just share if you want the presentation, the PPT of Dr. Jambunath.
Yeah.
You can start if you want.
Jambunath sir. Ashraf.
Yes, ma'am.
He's here.
ಅದು ರೀಸೌಂಡ್ ಬರ್ತದೆ ರೀ ಇದು ಆಗ್ತಾ ಇದೆ.
Okay, okay. Now?
ನಾನು ಮಾತಾಡಿದ್ದೆಲ್ಲ ಉಲ್ಟಾ ಇದು ಬರ್ತಾ ಇದೆ.
ಇಲ್ಲ. Now it's sorted.
ಸ್ವಲ್ಪ ಸರ್ ಕೇಳು ಸ್ಟಾರ್ಟ್ ಮಾಡೋದಾ ಅಂತ.
Yeah, he said yeah. He's giving.
Jambunath sir.
Yeah, he said yes.
Oh. Shall we go ahead?
Yeah, ma'am, please.
Yeah. A warm welcome to all of you on this Sunday evening. Today we have an excellent session by our Manik Nandan sir who is from JIPMER. So let us wait for his talk just in a while. Before that, I would like to introduce my president of this box society, Dr. Jambunath Gowda sir, who is the backbone of our office bearers in this 2 years tenure between 2021 and 23. So sir has completed his MBBS and MD in 1978 and 1986 from WIMS Ballari. He started practicing in a place called Kampli, where there were no facilities at all in those days. So he received ultrasound and IUI training from Mumbai and Kerala, started infertility practice since 1990. He is life member of FOXY, life member of ISAR, and he is life member of IAGE, socially conducting free eye camps since 1990, conducted more than 20 such camps. And sir has received the best Diamond President Award from Gangavati Lions Club. And he also had IUI workshop for rural gynecologists, and he conducted Muskan ultrasound workshop by Dr. Ram Murthy from Bangalore in the year 2015. I wholeheartedly welcome our president for this first webinar from our side, from new
Webinar.
office bearers of Box. Welcome, sir. Welcome, Jambunath
Yes,
Gowda, sir.
Thank you, man. Thank you.
Manish, next to the sir's PPT. Manish?
Mani sir will share Mani sir's PPT.
Right.
Yeah. Short CV, yeah. That one.
So now I would like to introduce to you our excellent speaker, Dr. K. Manikandan from JIPMER, who is a postdoctoral fellowship in fetal medicine, Mediscan Systems, Chennai, former associate professor of obstetrics and gynecology, JIPMER, research fellow in fetal medicine, King's College Hospital. He has undergone special training under National Teacher Training Course for Teachers of Higher Education, JIPMER, statistics and epidemiology training from Harvard's online initiative of Harvard University, quantitative methods in clinical and public health, principal investigator, DBT funded fetal growth charts project. And sir has focused on research topics like preeclampsia prevention and is special interest in teaching evidence-informed practice to postgraduate. Sir, I wholeheartedly welcome you for our first webinar from Box Society. The platform is yours, sir. Kindly give us some good presentation from your side. Thank you, sir.
Okay. I'm going to share my screen and I hope it is visible.
Yes, sir.
Yeah, your this one is seen now. Start, sir.
Yeah. Thank you, Dr. Gowda ji and Dr. Usha Rani ji and my dear friend Ashraf. And thanks, Corona, for inviting me during this Corona pandemic. It's a lovely Sunday evening. We'll keep it light because the topic is quite heavy. And I'll go to, let's say, moderate depth. And depending on the discussion, we can see if we need some more depth in discussion, because I say it's a mixed crowd. So the learning objectives from this talk should be understanding the changing determinants of placental exchange efficiency, the difference in the pathophysiology of early versus late fetal growth restriction, the difference in the predictive ability of current technology and technique for early and late FGR, the diagnostic criteria such as size, placenta, and fetal adaptation that will be used to make a diagnosis, and the difference in the fetal surveillance and decision making in early and late FGR. So it assumes that most of you are practicing, and of course, but most of the PGs who joined would have at least some introduction to fetal growth restriction. Fetal growth restriction is, I would put it as the most important problem that fetal medicine faces, rather than exotic Down syndrome or very rare anomalies or syndromes that diagnosis that excites everybody. Fetal growth restriction contributes to more than half of unexplained stillbirths. That is a catastrophe for any mother, and even more for any practicing obstetrician. So this is the landmark paper based on recode classification. It says about 50% of, around 50% of unexplained deaths were preceded by FGR rather than anything else. And a similar paper also came from Kerala, and so the demographics are very similar. We understand that in utero, there are 3 arms of progression. One is development, which is organogenesis, formation of the organs. And the second is maturation, where the organs achieve functional maturity. And these two are dependent on the gestational age. So if you allow the baby to wait in utero for more and more time, it is going to automatically happen. The third arm of, may I request Chetan also to mute a little bit because sound is coming. Chetan Anand. Or the others can mute. The third process that happens in utero is growth, which is simply increase in weight of the baby and size. But this, unlike the other two, is dependent on an intermediary called placenta. So placenta will be the crux of this talk, and also in the management, we should always focus on the placenta. Now, when we use the word fetal growth restriction, automatically all of us think that it's a small fetus. But a small fetus is not always a growth restricted fetus. It can be small because it is formed abnormally. Say, for example, a malformation or a chromosomal syndrome. It can be small because of its genetic constitution, the so-called constitutionally small. They can be totally normal. In fact, some of them are brilliant, like Sachin. What we are going to focus is the small baby that is small because it is starving. It is starving, that is, it is not fed properly by the placenta. In that case, an inherently normal fetus fails to achieve the genetic potential, and therefore it is classified as growth restricted fetus. Fetal growth restriction is arbitrarily classified into 2 phenotypes, that is, in 2 clinical subtypes. I say arbitrarily, I'll explain later, but it's useful for the management in the vast majority, but not all the situations. There is an early onset FGR and there is a late onset FGR. The early onset FGR is about 1/3 of all FGRs and tends to happen before 32 weeks, whereas late FGR contributes the bulk of FGR and happens after 32 weeks. Most of the early onset FGRs, about 50 to 80%, if you leave enough time, they will develop maternal preeclampsia, whereas this association is considerably less in the late onset variety. In the early onset, the disease in the placenta is severe, I'll explain what is perfusion and diffusion. Whereas in the late onset, the disease is mild. Early onset, because of its early onset, has a natural history where the fetus adapts, changes, shows some symptoms, quote within quote, and then the baby reaches an end point. Whereas there is no natural history in late onset because of the short time. As far as clinician is concerned, when there is early FGR, identification is easy, but management is challenging. And when there is late FGR, identification is challenging, but management is easy. So, in order to understand the pathophysiology of early and late FGR, I seek your attention to this slide. As the gestational age increases along the x-axis, the baby, the fetus, makes two kinds of demands on the mother through the placenta. The first is the nutritional demand, which the demand increases, the baby's nutritional demand increases. Initially, very steeply, and later on plateaus down. At the same time, the oxygen demand, the respiratory demand, is initially low and not increasing steeply, but around 32 to 34 weeks onwards, it starts increasing steeply. Now, if you see, there is a dotted line here representing about 41, 42 weeks. That represents the maximal metabolic throughput that any mother can handle. The humans can only handle about 2.5 times the basal metabolic rate. So that is the reason, in addition to the obstetric dilemma where the head is big and cannot cross the pelvis, another reason proposed for delivery of a child by about 40-41 weeks is the maternal system cannot handle the excessive demand of metabolic throughput required by the fetus. So if you keep allowing that, the mother will burn out. So that's the reason we go. So the point here is the oxygen demand or the respiratory demand exponentially increases in the late trimester. And at this stage, the nutritional accretion, the weight accretion is not that great. So any problem here, you will not see a great change in the size, but you will experience a great change in the hypoxic level. Right. So what does the placenta do? Placenta can be thought of as a thickened membrane, a respiratory membrane, which does exchange, nutritional and respiratory exchange. So it's basically a membrane with exchange efficiency. Throughout pregnancy, the placenta increases its efficiency. In the early half and into the early part of the third trimester, this exchange in efficiency, this increasing efficiency is done by adjusting, increasing blood flow on either side of the membrane. So you can see that this is the intravillous space filled with blood. This we are all aware of this diagram. And then you see that the villus tree is floating inside this intravillous space. So by transformation of the uterine arteries, and by arborization of the villus vasculature, the blood that comes to this area on either side, from the fetus and from the mother, increases throughout the first half and well into the early third trimester. And because of this increase in the perfusion from both sides of the membrane, you get increased placental efficiency. So the placenta's job increases, efficiency increases in the first 2 trimesters and early third trimester. But there is a ceiling. Now, in the late trimester, I said in the previous slide that there is an exponential increase in the respiratory demand. Now, to address that part, the placenta does a trick called villus ultrastructural changes, otherwise called as villus maturation. So what happens in this late change, the villi they produce microvilli, so there is increased structure, membrane for exchange. The thickness of the membrane decreases by special rearrangement of the nuclei of the cytotrophoblast and syncytiotropoblast. And inside the villi, the sinusoids, the capillaries become sinusoidal. They become distended and very thin walled, such that the blood stays longer, and the intervening membrane between the fetal blood and the maternal blood is just the basement membrane. So this is called villus ultrastructural changes or villus maturation. So the initial part of the placental efficiency is determined by perfusion. So that's the primary efficient determinant. And the secondary determinant is diffusion. And this happens later in the gestation. Now, perfusion, that is the changes in the vasculature of the uterine artery and in the villus artery, villus branching, they determine your Doppler findings, uterine artery resistance and umbilical artery resistance. Whereas once this is complete, you won't see much difference, much change in the villus, in the Doppler of uterine artery or umbilical artery. When diffusion becomes a problem, you will not see much change in the umbilical artery or in the uterine artery. So I hope this point is made understandable by understanding this principle. When perfusion is okay, that is when the initial period of placentation goes well, you will have normal Doppler in the umbilical artery and uterine artery, or almost normal Doppler. You won't make much of a identification by just doing a Doppler. Whereas when the diffusion fails, we have to seek other mechanisms to identify growth restriction or fetal compromise. So when the problem happens in primary determinant, that is when there's a perfusion defect, the phenotype that we get is early FGR. When there is a diffusion defect, then we get a late FGR. Now, going back to the previous slide where I showed the respiratory demand and nutritional demand, you can easily correlate. When there is a perfusion problem early, you will have high resistance Dopplers everywhere. And because early in the gestation, nutrition is more impactful, the baby size will be automatically smaller. Whereas when this is okay and later problem comes, the baby size won't differ much. You won't expect a very small baby, but quickly the baby's oxygen demands soar and cannot be met by the placenta, and hypoxemia will set in quite quickly. So you won't have much time. When we say you won't have much time, we're talking in weeks, not hours. Okay, so with that in mind, let's revisit risk factors for fetal growth restriction. These are the traditional risk factors: obstetric history, how you performed in your previous pregnancy, any medical history, and what are the findings in current pregnancy. Severe malnourishment, either very thin or overweight, severe anemia, all these things should be severe. But having understood placenta to be the crux of the issue here, newer prediction factors gain more importance nowadays, or as good as the traditional factors. Firstly, because of the, let's say, global or ubiquitous use of down screening, all the screening except even NAPT, they all originate from the placenta, the analytes. So when they show some abnormality, but the baby is not Down syndrome, then this is going to be a risk factor for placental insufficiency. Specifically speaking, if the PAPE in the first trimester is low, or in the second trimester, the combination is high AFP, HCG, and inhibin, and low estriol, then this is a significant combination for placental dysfunction. It's called placenta profile. In short, you can remember when a lady tests screen positive, so you do an amnio or a CVS, but KT is normal, that is a high-risk pregnancy for FGR. Now, certain Doppler findings in first trimester as well as in second trimester, that is uterine artery Doppler. We know uterine artery transformation is important for placental functioning. So when there is high resistance, follow them up for growth restriction. Because placenta itself can show morphological changes, a good look at the placenta in the third trimester, in the target scan is also useful in guiding the surveillance. When the placenta is small area of implantation, when there is extensive subchorionic fibrin, when there is a single umbilical artery, when there is a velamentous insertion. So these things increases the chance that there will be placental insufficiency later on. So all this has to be taken into account, because when the mechanism is going to be a diffusion defect, that is late FGR, the prediction is going to be poor by any one principle. So the prediction in late FGR is not going to happen based on the traditional or even the newer risk factors, and it has to be clinical. So I hope in Bellary, all of you have or still have the practice of clinical examination of the antenatal mothers, measuring the symphysiofundal height. What you can do to enhance this practice is to plot it on a graph and follow the graph. If you don't have risk factors for early FGR, then the only thing you should be worried about is late FGR. And if you do this properly and plot it, you will not miss much late FGR. Okay, so let's come to the diagnostic essentials of fetal growth restriction. How do we diagnose? There should be three things to make a diagnosis. One is size abnormality. It can be absolute size abnormality, for example, a small baby compared to the centiles, or relative to the same baby. That is, you saw the baby at the 5th month scan. The baby's abdominal centile was at 50th centile, and then you saw the baby again at 3rd trimester, and the abdominal centile is at 15th centile or 10th centile. So relative to its own size, there is a drop in size. So that should be a criteria. There should be evidence of placental disease. Now this can be either from the uterine side, a high uterine artery resistance, or it can be from the placental side, that is umbilical artery resistance. And there should be evidence of fetal adaptation. So I'll put the slide next. Usually it means there should be changes in the middle cerebral artery. A word about AGA, SGA, and FGR. When I say size, automatically don't assume that only small size will be FGR. That was a concept long ago, but it is not true. If you follow that, there will be some bad instances happening. It is true that all small fetuses are not growth restricted fetuses. It is also true that not all growth restricted fetuses will appear small. When we take the size alone, we can classify fetuses as small for gestational age and appropriate for gestational age, the two green circles. The red circle represents fetuses that did not achieve the growth potential, and therefore technically they are the FGR. You can see that among the FGR babies, most of them, more than 1/3 will be, more than 1/4 will be small, but more than 3/4 will be classified as AGA. So if you go only by size, then you will miss a lot of babies which did not grow or achieve their growth potential. So this is very important. There's something called DELPHI consensus for defining early FGR and late FGR. It is essentially what we have discussed, but they have put it in numbers. For the postgraduates, this may be useful. The first thing you have to know is between early and late FGR is the cutoff for gestational age. Know it for exam purposes. but for practice, this is a bit blurred. The gestation age should be less than 32 weeks for early and more than 32 weeks for late. And in both cases, there should not be any congenital anomalies of the baby. Only then you can classify it as placenta-based fetal growth restriction. You can have a solitary criteria or you can have combination. In early FGR, the solitary criteria can be severe smallness. That is, the baby's weight is less than the third centile, or severe placental disease. That is, an absent end diastolic flow. A combination can be whatever I have told before. A relative smallness in the AC less than the 10th centile, along with any evidence of placental disease like uterine artery or umbilical artery PA, high resistance. Similarly, for the late, in late, you don't expect severe placental disease. So solitary criteria of AEDF doesn't come. If the size is small, then you can take it as late. Or if the size is relatively small, then you should have something else like umbilical artery PA 95th or a cerebroplacental ratio. I'll explain about this later. Now, let's try and understand what happens when there is early FGR. When there is early FGR, the placenta is insufficient to meet the demands of the baby, and therefore the placental insufficiency progresses. There are certain adaptations that happen in the baby, and therefore some manifestations of these adaptations. So initially, there is higher resistance to the uterine circuit and the umbilical circuit. So when you use Doppler, you will see higher impedance in the umbilical artery and uterine artery. Cerebroplacental ratio is nothing but a ratio of the impedance in the middle cerebral artery divided by the impedance in the umbilical artery. So cerebroplacental ratio. Because in the initial stage itself, the umbilical artery PA is going to increase because of the impedance. The CPR will automatically decrease from what is expected for that gestation. Now, with further hypoxia, more resistance and more impedance will happen in the umbilical artery with further disease in the placenta. And by this time, because hypoxia is starting in the baby will try to send more blood to its cerebral circulation. And because of this increased flow in the cerebral circulation, the impedance in the middle cerebral artery decreases. So this is manifest by a decrease in the MCA-PI. This will add again to the CPR. So when you do the CPR, already the denominator was more. Now the numerator is going to come down. So the CPR value will again come down. So there will be progressive fall in the CPR. Now placental disease worsens. There is more disparity between the demand and the supply. So what happens? Because of the higher disease in the placenta, it will progress to AEDF, absent end diastolic flow in the umbilical artery Doppler. Before this happens, there's something called aortic isthmus. Since it's not very useful for your practice, I will skip it there. That will also decrease. Now, because of the acidosis, the heart becomes stiffer. So there will be lesser compliance in the heart. So the vein that reaches the heart from the liver, that is called the ductus venosus, that will have more impedance. So the ductus venosus impedance, PI, will increase. Now finally, when there is severe acidemia and going to happen injury or death, the umbilical artery will start reversing, the ductus venosus will start reversing, and even the biophysical profile will become very poor. Okay, so a lot of theory. Let's concentrate on some case discussion so that you can relate to what is happening actually in practice. So let me take the example. I have a few case scenarios. If time doesn't permit, please feel free to stop me anytime. Case 1 is a primary, 24 years, married for 10 months, natural conception. At 14 weeks, she was referred for a second opinion for a first trimester screen positive for trisomy 21. And when we went through, the NT-NB was normal taken outside, but the PAPE was low, and that was the reason why the risk had come positive. So we counseled everything, and then the lady underwent chorionic villus sampling, and karyotype was normal, no Down syndrome. And then she went back to her obstetrician, and they followed up with her. The target scan was done with their unit only. They reported normal anatomy, but then at 24-25 weeks, by 26 weeks, they sent again saying they are thinking it's oligohydramnios. So this is the picture. Here you can see the placenta very bulky. In fact, you can see that this is the baby's limb trapped under that. There is hardly any fluid here, any fluid elsewhere also. It's because of the extensive subchorionic fibrin deposition that is seen. This is an abnormal damaged placenta, and this was the reason why the FTS came as positive. You can also see that the placental implantation area is small. Generally, by target scan, the placental length should be about 12 to 14 centimeters, and the thickness not more than 3 centimeters. So it's all gone here. So we counseled them that this is going to be a placental dysfunction for you, and we need to follow it up. Because we know that subchorionic fibrin can resolve later, we will follow it up based on Doppler and growth scenarios. So the next visit was at, this is the biometric table. You can see already that the estimated fetal weight is at 4th centile, and the abdominal circumference is 5th centile, and this is the chart, abdominal circumference chart. I use AC in the follow-up of IUGR fetuses because that's the most sensitive parameter. The umbilical Doppler and the middle ductus were all normal at this stage, so we could easily reassure them nothing is going to happen, we'll just follow up, and we gave some nutritional advice. And then she was serially followed up. I've skipped some slides. Comes 34 weeks, you can see that the placental bulkiness is still there, but there is some slight improvement. But because of the relative oligo all the time, the baby wasn't reached. The growth was maintained along the lower centiles and was beginning to drop even further at this stage, around 34 weeks. And still the MCA, which sort of predicts the baby's hypoxemia directly, was good. So there was no oxygen problem at this stage, and therefore the patient was reassured to follow up for some more time. So because we know at 32, 34 weeks onwards, the exponential rise of respiratory demand, we follow up even more frequently. So we followed back at 1 week. There was a slight drop in MCA-PA and a slight increase in umbilical PA. And these areas of subchorionic fibrin sort of decreased, but you can now see areas of calcification in the placenta. So she was advised delivery by 37 weeks, and she underwent LSCS in view of breech presentation at JIPMER. Baby was 2,200 grams boy baby. Baby was doing well and had one episode of unrelated seizures at 8 months of life, secondary to fever. So this is fine. This is the second case. So the point in the previous case was it appeared as an early onset, but behaved as a late onset. In the second case, this is a lady who naturally conceived at 44 years of age. And she was sent to us at 15 weeks for, again, screen positive for FTS, first trimester screening. The trisomy 21 risk was more than 1 in 50, and again, there was low PAPE. So again, we counseled her, and the scan showed at 15-16 weeks, this is the placenta. Very small and very abnormal. You can see expanded intervillous space. These are the dead spaces that doesn't take part in gas exchange. Now the placenta is called hyperinflated placenta. So we said it's an hyperinflated placenta, and because of your age, you may think of amniocentesis, but the prognosis will depend on how the placenta is going to function. So if she was excessively condyle and she was asked to go home, think about it and come whether you want a needle inside or not. So she went, she discussed with family, and then they came back and said, okay, let's rule out the trisomy, and then we'll see how the placenta behaves. And so she came back at 18 weeks. This is when she took the decision to undergo amnio. You can see the placenta really bad. This is bulky, a lot of subchorionic fibrin and very small implantation site. The fetal weight was even smaller and all parameters were less than the 5th centile. And by this time, she had echogenic bowel, a slight asymmetry of the cardiac chambers because of the IUGR. And she underwent amniocentesis and it came back as normal. So we called her again at 24 weeks, and this time it was full-blown placental disease. You can see the placenta very, very bad. But look at the umbilical artery PA. This is called reversed end diastolic flow. So this is the systolic flow forward, and then there is no flow in the diastolic period. But towards the end of the diastolic period, there is reversed flow. So this is indicative of very severe placental disease. So we said that this baby will be in too much hypoxemia. You are only 24 weeks. You are not going to reach there. So be prepared for an emotional journey of meeting a stillborn. Because it's 44 years old lady, so we know that there was always that huge attachment and disappointment that's around the corner. So after counseling, she went back, and what we heard was there was IUD after 2 days was confirmed, and we had actually recommended to send the placenta for histopathology, but what we got was only some clots, so we couldn't do much about that. This is an interesting case. So this was a doctor, and she was 27 years, primary gravida. She was on mild hypothyroidism on treatment, very low dose, and she self-referred for growth scan at 30 weeks. So at 30 weeks, this is the scenario. We checked with the previous dates and everything. That's one of the most important things you should do before you think of IUGR. First, check the dates, whether early ultrasound corresponds to the LMP, or do we need a revision of the gestation age. So the establishing a gestation age is very important. And since that's one of the first things that we do in our in fetal centers, that's usually taken for granted. But when you are not dealing with a fetal center, always make sure that the gestation age is verified with the early scan. So she was only 30 weeks, 2 days, but look at the abdominal circumference. It was lower than the 5th centile. When you see a red and 5th, that is lower than the 5th centile. As a response to IUGR or onset of IUGR, the femoral length also is on the borderline. It's not indicative of any dysplasia. And the umbilical artery was okay, the middle cerebral artery was okay, and even the uterines were okay. So we went and saw the placenta. Placenta looks very cute. So what may be the cause? Here it doesn't seem to be a disease in the placenta. There is obviously a drop in the nutritional status of the baby, but it's not a disease in the placenta. So it's very common in our people, maternal malnutrition or inadequate or qualitatively inadequate nutrition is very common. And doctors are high-risk people actually because of the workload and work stress. Even nurses, they don't take proper nutrition. So I sat down and we counseled her about good nutrition in pregnancy, high protein, a good mix of protein, not overloaded. And then if there was any stress, anything going on, take a break from work and all those things. And then she did that and came back after 2 weeks, and you can see that the abdominal circumference is already picking up. There is a catch-up growth in growth velocity. And the Dopplers remain normal. So we reassured her and we said, you continue whatever it is, but always be under monitoring. So she moved back to another place where she was planning delivery and then followed up there. 2 more scans, both were showing a good catch-up growth, and then she delivered at 38 weeks, 2,500 grams baby boy. And now unrelated to this growth issue, had a 1 week in NICU, but baby is doing very well. I'll move on to the 4th case. This is an interesting one. So this was the second gravida. She was a software engineer, husband a software engineer. They came to me right from the beginning of this pregnancy because in her previous pregnancy, she had an unexplained preterm IUD. That was the one documented. But when we asked more history, she said the baby weighed only 1,800 grams at 34, 35 weeks, which was less. We expect 2.4 kg at the time. And she had decreased fetal movements for a few days, and then the IUD happened. So the picture was classic of placental insufficiency, hypoxia, and missed late FGR. That's the usual scenario. So from the beginning, she was there with us, and the growth was optimum and good. So we were reassuring her, but keeping her under constant surveillance. So by 34 weeks, you can see, I'll just go back. So you can see that at the beginning, it was the AC. The abdominal circumference was at 50th centile, 60th centile around, and then it started falling to 39th centile and 29th centile. So you can see that there is some degree of growth velocity getting compromised there. This is brought out in this chart here. Now what happened, she at 34 weeks, again she said that she came for a routine visit because we had called her at 34 weeks, but she herself told, no, I am feeling sluggish movement for the past 1 or 2 days. Now if you see, this becomes very significant. There is a drop in growth velocity and she is saying sluggish, and there is a past history. So the umbilical artery, even though the value is within the normal, it shows a slight increase. There is some placental disease going on here. But look at the MCA. This is the indicator of fetal adaptation. So there is hypoxia going on here. So together with all these and the previous, we should be very alert now. And we called up the obstetrician and said, this one requires delivery, give steroids, deliver. But if you're not delivering, intensive surveillance. So that is what we gave in the report also. And the obstetrician immediately got alerted and she admitted, gave steroids, daily NST for the completion of steroids. In 2 days later, emergency LSCS was done because she had persistently absent FM and deceleration was noted in the NST. Baby was well, tried immediately and was discharged after 2 or 3 days. Now the next case, okay, I think this will be the last case. This is a little bit of a twist. This is a patient whose mother was a senior gynecologist. Her BMI was high, other than that, no other medical risk factors, but she conceived on ovulation infection. So 2 risk factors for placental insufficiency. She was referred to us at 32 weeks because an outside scan showed a high resistance in umbilical artery, but otherwise growth was fine. So this is the biometry in our visit. It was good. The baby's weight was good. The baby's abdominal circumference was good. But the umbilical artery was 90th to 95th centile, which was varying. And so extensively, I asked the question, why should the umbilical impedance be so high when the baby is growing well at 32 weeks? Well, the only answer that we could find out was there was a relatively fewer loops of umbilical cord. It was quite straight. So it's a short cord baby, and therefore it's showing some higher resistance occasionally, but occasionally normal also. And absolutely no hypoxia at this time because the MCA was quite good. You can see in this image, tall peaks and low diastolic flow. That's the sign of good oxygen status in the baby. So we asked for a 2-week review. We reassured her, don't worry, we will see you after 2 weeks. And after 2 weeks, the growth velocity was maintained, nothing to worry. The MCA was very good, so no hypoxia. But umbilical PA was again fluctuating in the 95th to 98th centile. So the high resistance was there and short cord was there. So we kept saying it is short cord, don't worry for now. Let's go closer to term and take a call. So she came at 36 weeks. The growth velocity was still maintained. You can see the AC here maintained. But here now you can see the MCA started to dip. This is explained by the pathophysiology we have already understood. There will be exponential increase in the demand for oxygen. And when there is a high impedance in the umbilical artery, this is not going to be met and you can expect a drop in the MCA. So we repeated again and again. You can see the difference in the MCA velocity here, the spectral waveform. There is a lot of diastolic flow now. So this has to be taken significantly. So then you can see here almost like a knot, true knot in the cord, but it was not So it gave a little bit scare, but then 3D solved the issue. Is not a knot. So we said, okay, you have reached full maturity by 37. So there is nothing to gain by waiting. And the baby is showing some adaptation. It's better to deliver now. And she underwent induction of labor, had 12 hours of induction. It was going well, but emergency section was done for fetal distress. Again, expected when there is a short cord, and the on-table finding was a short cord. Okay, so with that in my background, let's put the management of FGR into generic terms. Early FGR, the management starts with counseling. This is very important. Early FGR means placental disease is high, heavy. You will have abnormality in the placental Doppler, umbilical Doppler, sorry. So that should be the early FGR. When umbilical Doppler remains relatively normal, don't label it as early FGR, as we have seen in the first case. Counseling is very important. If you have a fetal medicine team, that's the best thing. We do counsel here totally from starting to ending, how it's going to happen, what are the disease is going on, how a multimodal surveillance is important, and how the mother has to be monitored for PE. And we should agree the delivery threshold based on the existing NICU facility and the patient's affordability. And we should also agree on where to deliver depending on the gestational age. That means in utero transfer is the best. And most importantly, we explain that there is a 2% risk of fetal demise in early FGR, even when under intensive surveillance with the fetal medicine unit. So all this is counseled when the diagnosis is made. Now, early FGR, the progress is monitored principally by umbilical artery PA. When the umbilical artery PA is normal, then you can safely review after 2 to 3 weeks also, depending on if you're very early. If the PA starts to be high but still present positive flow, then you can review between 1 and 2 weeks. But when umbilical artery shows absent end-diastolic flow, it is no more a surveillance tool. Then you have to switch to monitor using a ductus venosus, and you can push the time of delivery based on the ductus venosus. Remember, when you see AEDF, it does not mean you have to press the panic button and deliver the next day. Typically, you can get 1 week. In most cases, you can get 10 days after AEDF in a well followed up case. Now, when to deliver? When you go up to 32 weeks, but AEDF has set in, then you should deliver. You can go 32 to 34, but mostly if a good NICU is there, you can deliver by 32 weeks. If you are following it up as an REDF fetus with ductus following up, you have reached 30 weeks. If your NICU is good enough, deliver. If you are following even before that FGR, already AEDF has set in, REDF set in, you are doing only with DV, ductus venosus. Then if you reach 28 weeks and the ductus venosus PA is high, that is high resistance in ductus venosus, you should deliver. In all these scenarios, if mother develops preeclampsia and develops indication for delivery, then that supersedes everything else and she has to deliver. That is understood. Now, there are certain standard interventions that you can do to improve the preterm outcome. First and foremost is in utero transfer. You have to decide which NICU is suitable for that couple after discussing with them, and you should ask the lady to go and deliver there. You can follow it up close. Before that, she can go and get oriented with the clinician there, the NICU team there. But once the threshold is reached, the delivery has to happen there, not transferring the premature and growth restricted fetus in a box. Cesarean delivery is the mode of delivery. Whenever there is AEDF, there is no role for induction of labor or vaginal delivery when there is AEDF, unless you're disregarding the baby. Steroids, well-timed steroids will prove very beneficial. As I told you before, just because you saw AEDF at 29 weeks, don't press the panic button and give off steroids. Just because we have to take an action. No, the action is monitoring. When you see the ductus venosus PI increasing, that is the time to steroid. When the ductus venosus PI increases, give steroids, 2 days, third day you deliver, that baby will be fine. Magnesium sulfate. When the baby is going to be delivered at 32 weeks or less, then 24 hours before, within the 24 hours before, typically I say, finish the magnesium sulfate, 4 hours later you schedule the cesarean section. So there is a regimen called Maret's regimen, which we can use in periphery also. You take 4 grams of magnesium sulfate, put it in 100 ml of normal saline and run it by a drip for half an hour. So that should be okay. No, nothing to worry about the mother. So these are the interventions which have been proven and shown to improve the outcome whenever you are doing a preterm FGR delivery. What does not work out, I will do in the discussion. Your severe bed rest, profound bed rest, or amino acid arginine, sildenafil. I think, yeah. So these are the things, they don't really make much of a difference. In fact, sildenafil is shown to be, in fact, dangerous, harmful also. Now, late FGR management, to summarize, it's more important to correctly time and deliver the baby before too much hypoxia sets in. And we can't do it by waiting for it to go for AEDF or REDF. That doesn't happen in late FGR. So it should be a combination of CTG monitoring, fetal movements, and MCAPI trend. If the trend is important. And have a low threshold to deliver. Be ready to deliver anytime some doubt comes. And most deliveries will be around 36, 37 weeks. So that also remember, because of the exponential increase in the oxygen requirement. In late FGR, induction of labor is perfectly acceptable, but fetal distress will supervene in about 30 to 50% of the cases. So discuss that with the lady. If they are motivated and you are resourced enough to monitor for fetal distress, induction of labor is acceptable. This is about a last case, so let me skip that. So this is the summary slide. The points to remember is, in addition to traditional risk factors, think of placental morphology when you do a scan. That is also an indicator of late FGR or early FGR. Placental biomarkers, whenever you do Down syndrome screening, don't just look at screen positive, negative and leave it there. See what is the result telling about the placenta, that is reading in between the lines. And when you do a growth scan, always focus on growth velocity, especially AC. So if the AC starts dropping, put her under more surveillance. The essentials of diagnosis is a combination of placental disease, size, smallness, and fetal adaptation. For the PGs, know that the phenotype of FGR can be classified based on gestation age, but keep it for your theory discussion. In practice, the classification and behavior is based on placental disease, which is reflected by the Dopplers, especially umbilical Doppler. And take a holistic approach in deciding the management, involve the fetal medicine team, neonatology, patient, and take many things into account. Most importantly, none of what we discussed so far apply to twins. That's a separate story, and we'll be happy, I'll be happy to interact with you people again for twins alone in a separate sitting. Thank you.
Sir, I got only one question from Dr. Gupta. Please explain, sir, Doppler finding. I just mentioned in chat box.
Yes. Please explain, sir, Doppler findings. Okay. Is there any comment from? Shall I go and proceed?
No, sir. You can go.
Yeah, please go ahead.
The question I got.
Yeah. I'm asking Dr. Usharani or Dr. Jambuna.
Yes, sir. Please go ahead, sir.
Yeah. Okay. So the Doppler findings I have explained in this. Let me go back all the way back to this slide. So the Doppler findings is how how it progresses will be based on the stage of the disease. In early stage, when there is just resistance in the umbilical circuit and the uterine circuit, you will get high resistance in the umbilical PI and uterine PI. Remember, in FGR, we use only PI, pulsatility index. We don't use resistive index. We don't use S/D ratio. None of them are valid for FGR follow-up. In obstetrics, only PI. The PA represents the impedance in the flow. So umbilical PA represents impedance of the flow of blood in the umbilical artery. So typically the umbilical PA will keep increasing and reaches a stage where no more flow is possible, and that is called AEDF. Sometimes it will start reversing, as I showed in that other slide. It's called REDF, reversal of end-diastolic flow. In the MCA, that is middle cerebral artery, the PA will start decreasing. That is because the baby will try to adapt more blood to the cerebral circuit, so it will start opening up the resistant tone vessels. So the PA will decrease. Does that answer your question, doctor?
Yes, sir.
Okay. Now, the role of infection in fetal growth restriction. Now, as I told you before, when you see a small baby, in order to put the blame on the placenta, which is the most common etiology, you should have evidence of placental disease, either placental morphology or Dopplers. You should have evidence of fetal adaptation, that is hypoxemia. But we should also not have abnormalities on the ultrasound. We suspect infection as an etiology in a small baby when there is abnormality in the ultrasound. Typically, calcifications in the abdomen, in the brain, effusions, bigger spaces. So these are the ultrasound clues.
Hello. How about using antihypertensive drugs? Means effects of antihypertensive drugs for these IUGR babies?
Yes, sir. When we use for chronic hypertension, when we use certain beta blockers, they have been associated with small fetal size. But when it comes to labetalol, if you maintain the target blood pressure, if you don't too much decrease the target blood pressure, then the uterine perfusion is maintained and there is no significant increase in HGA in those treated with labetalol, which is a mixture of beta-1, beta and adrenergic blocker. But if you use pure beta blockers, then there is a slightly higher chance of fetal growth.
Okay, thank you. Thank you.
Sir, what about Manik Nandan, sir?
Yep. Yes,
Hello.
Go ahead.
Sir, what about how much time we get for each parameter of abnormal Doppler, sir? Exactly.
Yeah, good question. We have to understand that we won't be able to know the starting of AEDF in every baby. Suppose you know, for example, you do everyday Doppler, then typically in singletons, onset of AEDF to demise is about 2 weeks. Okay. Usually we won't be knowing the onset, but a good ductus venosus will guarantee you that another 7 days is possible. Even so, when there is AEDF, the frequency of monitoring is every 2nd day or 3rd day with ductus venosus. But if the ductus venosus is good, low impedance in the ductus venosus, baby is moving well, that is also very important. It is not hypoxemic. It will give you about 7 days solid.
Okay. Sir, if it is reverse?
I will still put, because between AEDF and REDF, from hypoxemic point of view, not much difference. I will still put it around 1 week.
1 week. Sir, how often to repeat Doppler in such cases? Every day?
No, once you have switched to ductus venosus, then it's every 48 hours should be okay. If the ductus venosus starts showing impedance, more impedance, then you should admit.
It should interfere with the pregnancy.
Do it every day, give steroids, and then deliver like within 48 hours.
Sir, what about the treatment of oligohydramnios associated with IUGR, sir?
Okay, excellent question. If you see in the entire discussion, Liker did not take much significance or did not play a role. So, although this may be quite contrary to what we have been as obstetricians looking at Liker, it's a very reverent aspect to our practice. In FGR, Liker plays little role in diagnosis, in surveillance, and in threshold delivery. Diagnosis, surveillance, threshold delivery. In any of these instances, the role of Liker is very limited. At best, use it as a corroboratory evidence. You have solid evidence of Doppler, you have solid evidence of maternal feeling of fetal movements. Liker will be corroboratory evidence. And when you use Liker for monitoring and for decision making, do not use AFI. Always use only single deepest vertical pocket. AFI should be out of your practice.
Okay. So that means single
using
deepest
whether
pocket.
intrauterine supplements or oral, sir, to improve Liker. Which one you prefer?
Okay, I'll answer. I'll take this question into two parts.
Yeah.
Supplement to improve Liker and supplement to improve fetal growth restriction. Let's see it in two ways. When it comes to Liker, at or near term, if there is oligohydramnios, relative or subjective oligohydramnios, and you think it is due to maternal insufficient intake of fluid, it is very possible in hot climates. Dehydration is possible. The mother may not be taking the recommended 6 liters. So there, if you either give oral or if you give non-ionic infusions, for example, dextrose solution, you will see a transient increase in Liker. And that doesn't mean anything, but that proves you that that was due to dehydration or insufficient intake. And there ends your treatment for oligo. You don't treat an oligo. There's no need to treat an oligo. Now, if the oligo is part of IUGR, fetal growth restriction, now, can we treat the fetal growth restriction? That is the question, by supplementation. The answer is quite complex. I want all of you to listen a little bit in depth. In animal models and in all of mammals, placental insufficiency is associated with higher maternal levels of amino acids, lower placental levels and fetal levels of amino acids. And these babies in humans or in other mammals, these fetuses show features just like kwashiorkor. So the concept came that it is more like a protein malnutrition in the IUGR also. So, and that is the reason why protein supplementation, amino acid supplementation came into vogue. And there are mixed evidences in the animal industry regarding the role of amino acid infusion and supplementation. But in humans, clearly, there is no recommendation so far. Having said that, what I personally do is, my practice is more of a fetal medicine. I don't actually do the obstetric part. My referring physicians refer to me. When I make a diagnosis and during the follow-up, I ask them, what is the mode of nutrition that you are doing on? Most of them will be qualitatively poor, especially South Indian food will be full of carbohydrate and high calorie rather than protein. So I give them advice on protein diet. a mixed protein diet, animal protein and vegetarian protein, and say that this is going to go to the baby. Now, the problem with giving arginine alone or a few amino acids alone is that, here is the catch, even though you are trying to increase the intake of placental transfer of amino acids, the receptors can be overloaded with these few amino acids and you may miss out on the rest of the amino acids. That is, or maybe the reason why studies do not show an improvement, even though the pathophysiology is there. By only simply giving arginine or glutamine or arginine family, you will saturate the receptors and the rest of the things may not reach the baby. So it's better you give a nice protein diet advice and let it take the diet mix of all proteins, and that should be doing reasonably good for the condition. So don't treat the oligo.
Thank you.
So, sir, if there is no IUGR and there is only oligohydramnios, only fluid therapy is sufficient, then giving amino acid therapy.
No need for treating the oligohydramnios. If there is FGR and somebody reports oligo, somehow make yourself strong enough to ignore that and concentrate on the Doppler. Have they done the Doppler well? And if the single pocket is 2 centimeters or more, be safe. It's not going to happen. Anything is not going to happen. The mother reports good movement, Doppler is good, nothing is going to happen, and follow as per the Doppler.
Okay.
Again, no
Sir, suppose she comes at, sir, she comes at 32 weeks with AFI 2 centimeters, but no IUGR. How to follow her up, sir?
Yeah, again, yes, very good question. So, unexplained oligo in the late mid trimester is a common but harmless issue. Ask for other reasons for oligo, whether she has leaked, whether she has used NSAID. Even topical NSAID can cause transient oligo. We have cases where they do move, Volini gel move.
Yes,
Those things also can cause transient oligo. Ask for that, and if they are there, remove the cause. It should be okay. If nothing is there, Doppler is good, no IUGR, make sure she has enough intake of fluid. It should do well.
Okay, sir. Sir, and role of steroids giving at to what gestational age, sir, if at all we want to terminate?
Okay, this is okay. Our indication for steroid is to decrease mortality. So it is always indicated when the gestation age is 34 weeks and less. Up to 35 weeks in growth restricted fetus, it still improves survival. Okay. Now, beyond that, steroid does not improve survival. Steroid has small impact in transient respiratory morbidity. Now, we need to balance this with the potential bad effect of steroid. Normally, the baby themselves produce 3-beta hydrogenase enzyme in the brain, which will protect them against their own endogenous steroid. But when you give DEXA or beta, these are fluorinated steroids, they break this barrier and go and have an effect on the baby's developing brain. We don't want that to happen. So after 35 weeks, think twice. It's not really going to help the baby.
So even if you're doing elective repeat cesarean section, no need to, elective section, no need to give up to 39 weeks, they recommend now, sir.
Yeah, correct. This practice is mostly based on one study. I think the Aztec study, and they sort of gave steroid to everybody before an elective cesarean section, short of 39 weeks, and they showed a decrease in the respiratory morbidity. You can practice, but again, I will say transient respiratory morbidity is not a major issue in good NICU setup. If you don't have that, then you may have to do that. Yes.
Madam, I think we are done with the questions, ma'am.
Yes, sir.
Sir, Manish sir, can you please stop your sharing presentation so I'll share another presentation?
Okay, so
Thank you.
I
Thank you,
thank
sir.
you all.
Thank you, Manikrishnan.
Yes, sir. Thank you.
Sir, be there online, sir.
Yeah.
We'll, yeah, please be for a few more minutes, sir. Stay with us for a few more minutes.
Okay, Ashraf, thank you.
Yeah.
Excellent.
I'm going to stop sharing the screen.
Yeah.
Yeah. Okay.
Dr. Usharani, can I share that presentation?
Yeah.
Yeah, I'll send. Is it visible, ma'am?
Yeah.
Okay.
So just I wanted to just remind about the new parenteral iron preparation about iron isomaltoside. I just have few slides to tell about this, about the product. So since 20th century, early 20th century, we know that we are using various IV preparations for iron deficiency anemia. So mostly in last 5 years, we are with third generation iron preparations like the ferricarboxymaltose, ferromoxetol, and iron isomaltoside. The preparations available in India are mostly FCM, and which is there since around 2011. And iron isomaltoside, though it's approved in 2013, it is usually more used since last 6 months. It has come into market. Next slide, please. Manish, next slide, please.
Yeah, ma'am. Doing. Yeah,
So the points to take why we are developing new parenteral iron is we are searching for a molecule which has low catalytic or which has low labile iron, which is immunologically less potential with minimal risk of anaphylaxis, which has least metabolic imbalances, and no test dose should be required. And we can give a higher dose at a shorter time, and it can be given rapidly. And also thinking on the cost of treatment and overall hospitalization cost of asking the patient to repeatedly visit for further doses. Next. So we know the commonest indication in our field are antepartum and postpartum iron deficiency anemia, anemia in AUB, and those who are intolerant to oral iron. Though these and chronic kidney disease and all, they are usually used in the medicine part of the part of department. And we all know this Ganzoni's formula, which we use to calculate the total injectable iron required by the pregnant lady. And then coming to the various iron preparations, the generation wise, we know low molecular weight dextrine no more used now. Iron sucrose, which was a second generation, is also not being so much preferred these days because of its repeated visits that are required by the patient. And the other ones are FCM, and the recent molecule is iron isomaltoside, which have to little think over it of using it because it has a low molecular weight, 1000 Daltons, and still it is because it has a linear structure, unlike the spherical structure of FCM, it is more stable compound and has less release of labile iron once given into the parenterally. Next slide. So we know that with iron sucrose, repeated visits are required by the patient. Maximum dose given is 200 milligram in each visit, whereas unlike FCM, we can give 1000 milligram in a single infusion, whereas iron isomaltoside, we can give maximum up to 2000 milligram over 30 to 60 minutes. This is the advantage, and each ml contains 100 milligram per ml, unlike the 50 and 20 in the other preparations. So the main advantages I have to tell you is it has the least anaphylactic reaction and least release of non-transferrin bound iron once given. And also it has less hypophosphatemia compared to the FCM, which causes the 6H syndrome. So this is a slide showing where compared to iron sucrose, iron isomaltoside has rapid rise in hemoglobin rise by 2.7 grams in 11 days period. So this is comparing, showing the labile iron with isomaltoside is least compared to the other preparations. And here it is a slide showing that the hypophosphatemia caused by ISM is less compared to the FCM. That is the blue line, which is FCM, indicating FCM, and red line indicating the ISM. So there are also no changes with vitamin D and calcium levels with ferriisomaltoside compared to FCM. And the anaphylactic reactions noted in some studies are 0.8% with iron isomaltoside and 1.7% with the FCM group. So because of the less risk of hypophosphatemia, so and which is more with FCM, so the more safety drug can be thought of as IIM in coming future. So this is for IV injection, which is comes in a 5 ml vial. It contains 100 milligram per ml. So I request all the members to kindly try out this drug for new drug for the already it is there, but in Ballari very few people are using it. So I request most of them to try to use this for IV, which is also actually cost effective as FCM. But the only advantages are reactions will be less, high dose can be given at the single time, and it causes less hypophosphatemia compared to FCM. Thank you.
Thank you, ma'am. Just a minute, I'm just stop sharing my slide. If you all want, then we'll go offline first, then we'll discuss.
No. I would like to.
And
Yeah.
I request
sorry.
Ashraf, our treasurer, who has worked so much for this webinar. I request him to give vote of thanks and request that Maniknandan sir has really accepted our request so soon, and he has agreed to give in a short period of 5 days. He has accepted to deliver the topic, and it was really excellent topic, sir. Really, we had good points from you, which I was unaware of things before. Even though I did so much, completing so many years of my practice, you have really taken us into depth of the molecular level. Ashraf, I request you to thank sir and give vote of thanks to everyone.
Thank you, ma'am. Good to all members, delegates, colleagues, seniors, students, PG students, and all other friends who have come on this platform on this wonderful evening. I would like to take this golden opportunity to thank Dr. Manikandan sir, who's an ex-JIPMER faculty. When I joined JIPMER, unfortunately, he was out of JIPMER, pursuing his passion. I thank Manikandan sir for clearing all those basic doubts for all the practitioners, the subtle things that we needed to understand, that helped us in managing IUGR cases, presented in a very simple way. Thank you, Manikandan sir. We all know how busy you are in Pondicherry right now for taking this much time for us. And I also like to thank our president, Dr. Jambunath sir, and secretary, Dr. Usharani madam, for enabling this webinar. And I would also like to thank Corona Pharma Company, on whose platform this webinar was done, Core Connect. The entire team of Corona, including Minesh, Mr. Ashok, and all of them. Thank you all for this wonderful talk. Thank you, sir.
Thank you very much.
Yeah.
Thank you. Thank you, everyone.
Thank you, Mani sir. Thank you, Jambunath
Thank you
sir.
very much,
Thank you.
Jambunath sir.